I'm going to talk to some of the questions that we know about infant development and baby wearing and questions that come up specifically when it regards hip and spine development. So hip development occurs actually very early in utero. By the 7th week, both the ball and the socket are already in place. And by the 11th week of gestation, the ball and socket have taken on the appearance they will have when the baby is born. One of the important things to know about the way that our bones develop is a lot of our bones start with a cartilage precursor, and that cartilage turns to bone. And some of this cartilage turns to bone when you're age 10 to 12, and some of it earlier in life. So we call these the cartilage precursors ossification centers or epiphyses, depending on where they are in the body, just so you sort of understand my terminology. So by the time the child is 4 to 7 months old, the ball part of the ball and socket, which is the proximal femoral ossification center, starts to turn to bone. And then by 8 years, most of the hip is completely developed with bone, but there are still open growth plates that will continue to develop. And as these growth plates develop, the pull of the muscle on the bone surrounding it, the amount of weight bearing you do, your adequate nutrition with vitamin D and calcium, as well as the blood supply can all affect how the joint develops. And there are diseases that can lead to changes in how the hip develops, even through the teenage years. One of the most important things that we worry about as pediatricians is developmental dysplasia of the hip. And there are lots of risk factors that we have identified, primarily genetics. If you have a parent or a sibling that had developmental dysplasia of the hip, which means that the hip dislocates, and it's not supposed to do that clearly, you are much more likely to have developmental dysplasia of the hip. Female infants and any condition which decreases the amount of space in the uterus will increase your risk for developmental dysplasia of the hip. So it's very important when you're in utero for that ball and socket to have appropriate contact with one another, for the socket to develop nice and round and deep to accommodate the ball for the rest of the life of the hip. So we know that this contact, this appropriate contact with the ball actually located in the socket, causes the socket to develop in a nice round fashion. So having not enough fluid in the uterus or oligohydramnios, being in the breech position, which takes up a lot of space, increases your risk. The cesarean birth is most likely a result of, doesn't really increase your risk for hip dysplasia, but people who have decreased space in the uterus end up with C-sections more often. But also typically large babies, so babies born to moms who had diabetes during pregnancy are at increased risk, and first pregnancies because, again, the uterus doesn't stretch out quite as well. After birth, we know that swaddling infants, such as the Native American style, they used to strap them on a board with the legs out straight so that you could carry them on the back and continue to work. Having the legs in that completely extended position caused the socket to not develop as deeply, and so kids ended up with more developmental dysplasia of the hip when in that type of carrier. The other thing that we've noticed is that other musculoskeletal abnormalities, so torticollis, which is the tightening of the neck, or club feet, are associated with developmental dysplasia of the hip. And so when we notice these abnormalities in kids, we follow them very closely for developmental dysplasia of the hip. So there are two types of developmental dysplasia. The first we notice basically at birth. So in that initial exam after birth, one of the things that we do is we test the hips and we see if they dislocate. And in many children, we recognize this hip dislocation immediately, and we place them in this little purple harness that you can see here, which is called a Pavlik harness, which keeps the hips flexed, which means bent up, and abducted, which means spread out. And what that does is it nicely centers the ball in the socket, which causes the socket to develop in a nice round fashion to accommodate the ball so that you have a healthy hip socket. The kids that we worry about most are the ones that actually develop it a little bit later. So we know that they're born with hips that are a little bit shallow, but not so shallow that the hip dislocates. And if you don't keep that hip in good position, it can become a hip that dislocates, which is why we continue to examine the hips. Every time you go to the pediatrician's office, you see them take off the diaper, push the hips out, and pull them back in. And that's what we're looking for, is to see if the hip dislocates at 2 weeks, at 1 month, at 2 months. We always check the hips to make sure we don't have a kid who's developing developmental dysplasia of the hip later on. And as long as we catch them before 6 months of age, we can typically use this Pavlik harness. And depending on how early you catch them, you wear it for weeks to months, depending on how long it takes for that socket to get nice and deep. There's no evidence that the carriers, the front carriers that we're using now in any way contribute to developmental dysplasia of the hip. There haven't been any case reports reported that anyone thought that this was in any way associated. And when I talked to all of our pediatric hip surgeons at Rainbow, they looked at me as though I was nuts. They're like, well, of course not. They keep the hips nice and flexed and abducted. Of course they shouldn't be related to that. So I think that this is something that we certainly don't need to worry about right now. So how can we protect kids' hips? We allow them to have free range of motion of their hips, so they should be able to move their hips around. So even though we know that swaddling is very good for infants, it helps them sleep and it helps them feel comfortable, the legs should be free to move around, and especially to get up in that flexed and abducted position. And we look for carriers that allow them to do that as well. Now, I don't expect anybody to run around measuring the degrees of their hip flexion and abduction in kids, but in the event that you would want to know, the ideal hip position is between 100 and 110 degrees of flexion and 50 to 70 degrees of abduction. And that's sort of the angles that we use when we're treating kids who have developmental dysplasia of the hip. And depending on how, there are kids that will even cast in that position for weeks at a time if needed. And then, so now I'm going to move on to spine development. The changes in the spine are very fascinating. The spine grows a little bit differently than other bones in the body. Most of our bones grow from growth plates at the end. So you have a growth plate at the end of your wrist and at the top part of your elbow, and that's how the bones in your forearm get long. What happens in the spine is actually the bones grow from the middle, so they kind of grow out. Sort of in a circular fashion. And changes in the vertebra can occur all the way up until about the age of 18. There are several of the last growth plates that close that can actually make you tall. So once your leg growth plates are done being tall, you can actually get an inch or so left from your spine as those bones in the spine continue to expand. And you can just sort of see some of those changes here in a diagrammatic fashion. And then here with x-rays, you can see how very different the bones look, how the curvature of the spine changes from early infancy to childhood until the late adolescence when the spine is the typical shape that it takes on. So you see changes in the shape of the bone as well as the spine curve, and then the things we can't see on x-rays, that the discs change, and those especially change after adolescence. As we get older, the disc gets smaller and less elastic and less happy, and we get more back pain and more herniated discs as we get much older. So there is no defined medical best position for a child to be in to ensure good development of the spine. But what we think is that children should be permitted to move around some. We want them to be in different positions during the day, and so we encourage that. We like everybody to have tummy time. You should be spending some of the time being held by your parents. You should be sleeping in your bed, and you should be carried in a baby carrier. So just not any one position during the day. And there's no evidence to date that any infant carrier that's available on the market has in any way caused any child's spine to develop improperly. There's a specific spine disorder that people worry about. There are stress fractures in the low back, which are called spondylolysis. And that's just the long fancy name for stress fracture in the low back. There is no evidence at this point that any infant carrier of any model or brand causes an increased risk for this. What we do know is that the people who tend to get these stress fractures in the low back are involved in sporting activities that increase your risk for that. So basically, any sporting activity where you're doing a lot of leaning back increases your risk for stress fractures in the low back. So we see it very commonly in ballet dancers, gymnasts, and also football linemen, which doesn't sound right until you remember that they line up on the field, they extend their back, and then big people run into them. And so that's where we see it most commonly. But we see it in all sorts of different sports. So that is the big risk factor that we see for these stress fractures in the low back. The spine surgeons that I've discussed this with, because this is a very hot topic in the sports medicine world, what do we do with these people with these low back stress fractures? Some people think there's probably a genetic component to this, but as far as they know, nobody has suggested that there is an environmental component during the early years, other than these sort of high-risk sporting activities which could contribute to it. Professor Klaus Parsch says that the baby Bjorn carrier might counteract circumstances that are unfavorable to development of the spine. Should a baby face in or out in a baby carrier? Well, it sort of depends on how old the baby is. If they're too young to hold their head up on their own, they should be facing in, because then they can lean their head against your chest for support. One of the great things about this is everybody is very attuned to SIDS, sudden infant death syndrome, and one of the great things about the baby carriers with the baby facing in when they're very young and can't control their head is you know if your baby's breathing, because you can feel them breathing against your chest, you can feel their chest rise against your chest, and you can change the infant's head position if you're at all worried about it. And this is, I don't know if anybody here has ever had their baby in the NICU, one of the things you have to be able to do before you go home is keep breathing while you're sitting in a car seat. And so they'll actually test kids while they're in a car seat to make sure their head doesn't flop so far forward that they don't keep their oxygen levels up. But this is sort of a nice, sensible mom way to know if your baby's breathing well is you can actually feel them breathing. And then once they can hold their head up, they should face out. And a lot of the developmental specialists in the world recognize that at about the age of 4 months or so, when they can really support themselves, you'll notice your babies, if you hold them at that point at the waist, even though they can't sit up on their own, if you hold their waist, they can sit up, they can turn their head, and they look around. And they've been described as a hatchling at that point, becoming very socially interested in the wide world. And these are the babies that everybody loves, that 4 to 6 month old that all you have to do is look at them and smile, and they'll giggle and smile, and everything you do they think is fascinating. And they love looking out. They love facing the world at that point. And that's a great time to face them out, and developmentally appropriate time to face them out. And we really think they actually enjoy it.